The first part, I just want to talk a little bit about uncertainty around COVID-19 and whether it matters. The thing with uncertainty is it's very important for scientists to have doubts and uncertainties, but it is a bit of a problem during a global pandemic. When you have an emerging disease which is spreading in many different contexts, and where we don't know the epidemiology, we don't know the characteristics of the pathogen, we don't know how it responds in a range of contexts, we're really struggling because what we don't have is a model by which we can look at our response. And you will have noticed lots of people trying to use previous epidemic models. For example, how did we respond to the 1918 pandemic, etc., etc. The data themselves are uncertain, so we get lots and lots of endless reporting of where are we, league tables which are essentially meaningless because we don't know what anybody is reporting at the moment. But the data are uncertain, and that makes public policy responses quite difficult. And even the data on excess deaths, which is probably the most useful data that we can have at the moment for understanding roughly the scale of what we're dealing with, is a little bit problematic. And that's largely because it's a bit hard to know what else is going on. All the other seasonal effects are going to be uncertain. It's quite difficult to say for sure that all of what we're seeing is directly COVID-19. On top of that, of course, we're seeing a lot of excess death, which is a sort of byproduct of COVID-19. So all the people who are maybe not going to hospital with underlying health conditions. Another approach to this is to use empirical models, given that a lot of the epidemiological models are not really super useful, or certainly weren't in the early stages of the epidemic. And I just want to give a shout out to Clara Prats and her colleagues at UPC in Barcelona. They've been using empirical models based on reported cases and fitting a Gompertz equation to really have a look at what they think might be happening in Europe. I put the link in this presentation if anyone's interested in looking at the reports. Their models in the early stages of the epidemic are very uncertain, but they have been zeroing in on quite a high level of certainty around predicted final numbers of cases and actual reproduction rates. And one of the things to also bear in mind, though, is that because there's so much uncertainty, because we're in very early stages, we tend to be looking at the big headline numbers. And one of the things we're not looking at is the skewing of impacts on certain groups in society. A really nice paper from 1978 that looked at the incidence of coronary heart disease in people that worked for the British government in Whitehall, so basically civil servants, but disaggregated by their pay grade. And you know, there's lots of really cool data in the paper, but the bottom line is the less well paid people were, the more likely they were to die of coronary heart disease. And this is a story that we see over and over again, that there is a correlation, not necessarily a causal correlation, but a correlation between being badly paid or being poor or being in an insecure environment and a higher disease burden for a very, very significantly large number of determinants of disease. And I'll come back to that point later. The thing is, as public health engineers, we've been dealing with uncertainty forever. I mean, I don't think I've ever really worked myself on a project where we've really known what's going on. There are some specific reasons for this, particularly in the arena of public health engineering. And the major one is that infrastructure and behaviour change interventions, which are the main tools that we have at our disposal, are implemented and work, you know, they are effective on a totally different timescale than most disease outbreaks. You can't implement a piped water supply system for the whole of Lagos in the same timescale, for example, that a typical cholera epidemic occurs. Now, sadly, that might be less true than usual for COVID, but it's still very difficult to mobilize the kind of big interventions that we need. Even behavior change, if you're really going to do it well, is a really tricky thing. I mean, if you think about hand washing, it's not like we haven't known since, well, the first national campaign on hand washing in the UK, I think, was in 1942 in an attempt to reduce coughs and colds and flu during the war in the UK, during the Second World War. So it's not like we haven't known about these things for a long time, but behavior change and the infrastructure both work on these much longer timescales. We also have a problem because there's a whole bunch of very, very significant disease burdens which are going on all the time anyway. I haven't looked at the numbers yet, but I think it's going to be plausible to say that for some countries, COVID will be dwarfed by the morbidity burden of some other, real boring, old, familiar disease friends that we've been dealing with for a very long time. And they don't tend to get the same attention that COVID does. And the other thing, which we know from what I just said in the first part of my presentation, is that the health data are really ropey. So we don't really know exactly what people are sick with anyway, most of the time. So it's not that easy to really laser in public health interventions on specific disease responses. We think about clusters of diseases in terms of their environmental characteristics, and we design interventions that are going to be broadly effective for all of the diseases that fall within a category where we think that those categories of diseases are particularly common in a given place. So if we can get a sense of the types of things which are making people sick in a particular place, we can very often target interventions that are going to help them. One of the important ideas here is that we're interested in how does an infectious disease get transmitted? And there are a set of factors which determine how effectively a disease can get from me if I'm sick to Tom if he's not sick yet. And these are the number of pathogens that are excreted or that get out of your body. So the expelled load, we would call it, if we're not only talking about excreted infections. How long does it take for the excreted pathogen to become infective? So is it immediately hazardous or does it have a latent period? How long does it survive outside the body? Can it multiply? How many of those pathogens are required to meet another person in order for that person to become infected? And is that person more or less susceptible to the infection? This is the flow chart. So some number of pathogens are expelled from the body. They have these characteristics of latency, persistence, and multiplication. On the basis of that, they become a certain number of pathogens which are going to meet another host. And if that number of pathogens is sufficiently high, that host is going to be susceptible to infection. First category are the non-latent, non-multiplying, low infective dose infections. So these are all the viruses and all the protozoa. And probably when we think about public health interventions, in many of the countries where I work, we're quite often looking for either rotavirus or norovirus as exemplars of this. These are very common infections, as we know, and they're not only airborne and hand-transmitted infections, they are also excreted infections. Because viruses are not very tough outside the environment, they don't last very long, they don't have high latency, most viral infection, or the most significant burden of viral infection, happens on a person-to-person basis and very often inside the home, so at the domestic or peri-domestic level, or in places where people regularly meet together. So schools are a typical place where you get big outbreaks of norovirus, for example. So when we think about public health interventions, if we have very high incidence of viral disease in a place, then that probably tells us that people don't have enough water supply at home, and they're not practicing adequate hygiene. And if we can improve those two things, usually or very often, we might be able to reduce the endemic burden of viral infection. Viral infections are also quite closely associated with housing, and that's because of the ability to keep your environment clean. So if people live in very kutcher houses which don't have plastered walls and hard floors, it's really difficult to keep surfaces clean. If people are living in very crowded environments, you're going to be increasing the rate of transmission. Now we can contrast category 1 infections, just for the sake of the argument, with category 2 infections, which are your non-latent, medium to high infective dose, persistent and multiplying infections. So this is all your bacteria. There are loads and loads of endemic bacterial infections that are there all the time or that flare up from time to time. And then we have our big epidemic friend that we have to worry about a lot, which is cholera. Now, the thing about bacterial infections is that there is another set of transmission pathways. So all the same direct person-to-person transmission can occur, but because bacteria are much more robust outside of the human body, we have to really worry about transmission primarily through foodborne pathways and also through slightly longer route water-related pathways. So we do worry, for example, about cholera in the effluent from hospitals, for example, and if people are going to be exposed to that. So if we have a lot of bacterial infection in the environment, we've got to not only worry about hygiene and household cleanliness, but we've really got to think about capturing and managing fecal sludge and waste in a really effective way. And if we're going to use that, not as waste, but as a resource, for example, for irrigation and for growing crops, we've really got to worry about how we manage that process and whether we provide enough treatment. Now, the other thing I want to say about cholera is the other thing that cholera tells us for a slightly different reason is we get cholera cases. Cholera is a notifiable disease, so we have some idea of the number of cases of cholera in any given year. This is the WHO data up to 2016. This isn't perfect data because many countries don't report cholera epidemics. You might be interested to know that Ethiopia hasn't had a cholera case for the last 40 years. It simply has had quite a lot of acute watery diarrhoea. So, you know, that's what we have to do with the data we have. But what you can see here, if you look at the purple parts of these bars, we can map these to disasters. And as our friends in the No Natural Disasters movement will tell us, these may look like natural disasters, but they are not. They are human disasters because a natural event has precipitated a public health disaster because of the nature of cholera disease, and very significantly because these types of episodes result in large population movements. And we know in infectious disease science, if you want to call it that, that when you have lots of people moving from one place to another during an outbreak, that's something you really want to worry about. Now, generally, we don't worry about that so much in a viral epidemic, but where we have a new emerging virus, which is extremely infective and has a very high strike rate, we might still want to worry about this, and I'll come back to that in a moment. An understanding of the broad landscape of disease in a place can tell you a huge amount about what types of engineering interventions are going to be the most effective and the most useful. And I really, really regret this kind of splitting apart of the sort of infrastructure sector, if you like, or the, I don't know, WASH sector, if you want to call it that, from the public health disease sector. And I think it's something that really, I hope that one of the things that will come out of COVID-19 is a recognition that we need to stitch these things back together. Right, so let's just talk about COVID-19, or to give the pathogen its correct name, the Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2. So it's a coronavirus, an enveloped virus. Let's just think about it in terms of our environmental classification for a moment. So, excreted load. Now, the thing that most people know about coronavirus is that it's commonly spread in large numbers in droplets from the nose or mouth, I should say, when coughed. 2 meters is a kind of sensible, comprehensible distance, which reduces the chance for a droplet to pass from myself to somebody else. We should also be worrying about aerosols, non-droplet airborne spread. This has implications primarily in crowds, and also has quite serious implications for when we all start getting back together again. So it's a really important area just to keep an eye on, and there is a SAGE subcommittee specifically looking at that. However you feel about SAGE, there are some sensible people definitely looking at that. There's some uncertainty. There's a bit of evidence that possibly we're seeing some mutations in the pathogen. It's really unclear at the moment. Certainly what is seemingly the case is that we don't yet reliably have a way of saying this person has got all the resistance that they need to ensure that they will not be reinfected. That's the piece of the puzzle we haven't got yet. Something that people haven't talked about very much is somewhere between 2 and 27%, depending on where you are, of people who have confirmed COVID-19 have diarrhoea. So that's quite important, because when people have diarrhoea, then we tend to get a lot more excreta accidentally in the environment than we would otherwise. There have been viral fragments found in fecal matter, both from people who have active disease and also after recovery. So once this virus is out in the environment, it's pretty short-lived, unless it's in a really, really lucky niche spot. It can't multiply. Now, viruses are not latent. They need to get into another host cell really fast. They don't function on their own. They're not living cells. They need a carrier cell. So what you've got to do, what you've got to think of your job as a public health engineer is to cut them off before they can find a new host cell to go and infect. That's what we're looking for. Also, it's a non-enveloped virus that makes it really, really susceptible to the action of soap. So one of the reasons why hand washing with soap has been pushed so hard is because soap specifically is effective against this type of viral infection. The bad news is that the infective dose is very low. Infectivity at the moment is very high and case fatality is high. So the only reason at the moment why numbers are dropping is because people are not coming into contact with each other. Numbers are not dropping because infectivity is dropping, and that's something that's really important to hold on to. We're not going to see that happen for quite a long time if this virus is like any other virus we've ever seen before. The other bad news is that there are lots of susceptible hosts, but the bottom line is that everyone is a susceptible host at the moment. This is an emerging infection, and that is actually, although terrible, quite important for us as WASH people. So it's a type 1 pathogen. What does that tell us? Well, as WASH people, as environmental health engineers, it tells us that we've got to focus most of our control at the domestic and peri-domestic arena and in working places and public places where lots of people meet together. So what we've got to do, we've really got to focus on the behaviour of people who are potentially infected, and we've got to try and create barriers, either physical or behavioural barriers between them and other people. For most people who are going to be affected by COVID, they're living in a totally different environment to the one we're living in, and that is a place where generally there is patchy, poor quality, poorly managed WASH services. And those WASH services are immediately going to come under strain because a lot of the people that work in those WASH services are being diverted to other tasks. You're very often in an environment where there's a highly mobile population, and many people live in hazardous or insecure settings. So in India, for example, there's been a huge problem because everybody in the informal employment sector in urban India has basically walked home in the last 5 weeks, carrying potential infections right across the country. And it's also important to recall that there's a layering of risk. COVID has taken the headlines, nobody's really paying attention. But for example, I work in East Africa a lot. Lake Victoria is currently at its 1 in 100-year highest ever levels, in fact, highest ever recorded levels. There is pluvial flooding affecting about 30% of the population of Kenya. This is almost certainly going to result in a second plague of locusts, because we know after intensive short rains we're going to get another locust infestation on top of a previous one which has really constrained food supplies, and we're seeing mass displacement of populations, and there's an Ebola outbreak in DRC. So just want to remind everybody that COVID-19 is not actually the only, or even in some cases the biggest problem that people are trying to deal with at the moment. This is what I've been thinking about. What are the implications for WASH? So let's just think about hygiene as the first thing. Now, we know there's a lot of evidence that transmission of respiratory infections is greatly aided by person-to-person contact, and therefore that personal hygiene is a really important intervention. And we saw that in the SARS outbreak, we saw it in Ebola, we know it's true for seasonal flu. Washing hands is a bit more difficult than it should be because hands actually offer protection to the virus because of all the little creases and kind of crimply bits that you have in your hand. And that's particularly true for viruses which are encased in liquid droplets. So one of the things is we've got to, and you will be aware of this, it's not just about washing hands, it's about washing hands in a very particular way. Transmission on inert surfaces, although viruses are not very tough outside the body, they can last reasonably well, again, particularly when they're in droplets. So hands, doorknobs, shopping baskets, trolley handles, all of those things are a problem. And for all those reasons, hand washing is extremely important. We know that. But several things are going to have to change, and one of them is the definition of critical times. One of the problems we have is that in the public health sector, in the WASH sector particularly, we've tended to focus hand washing efforts on telling people to wash their hands after defecation, before eating and before preparing food. Now, that has been for a very pragmatic reason that it's very difficult to get people to do more than that. We know that soap is highly, highly effective, but we do have a serious problem with supplies of soap in a lot of the places where the virus is hitting very hard. But I think one of the things that has been a little bit overlooked or isn't discussed enough is that if you're going to practice basic hygiene all the time, you need a lot of water. It takes about a minimum of about half a litre of water to actually wash your hands effectively, really properly. And if you're going to be doing that typically, 15 times a day, that's a lot of water for a household, which may have very limited water supplies. So one of the things that I think is most important about the hygiene message, we have to keep pushing the hygiene message. It's been a very hard message to push. And what communities very often tell us is we'd love to practice better hygiene, but we don't have enough water. So the absence of readily available water supplies at home is going to severely constrain our ability to promote adequate hand washing. And if there is no water at home, people are going to go out to collect it. So the implication for water supplies is we've got to really think hard about how people are currently accessing their water. Huge numbers of people just don't have enough water supply at home to be able to practice this notional hygiene. The one water quality issue that's going to be a problem is if people don't want to use the water that's made available, if it's not attractive enough to use or doesn't look like a good way of washing their hands, people will of course go out and use less safe options. And the other thing I want to remind everyone is it's not just about domestic water supplies. So about 50% of health centres and hospitals in Africa don't have a basic water supply. So that means they don't have a water supply within half a kilometre. But what about prisons and orphanages and old people's homes and markets and transport hubs? And many of you will have seen some of the pictures from India that really bring that home. So this is a water access issue primarily, in my opinion, and it has direct short-term public health implications, not just for the individuals concerned, but for everybody. So category 1 infections, they present a risk to everybody if they can't be controlled at the household level by everybody. So in the short run, governments are really skeppering around trying to worry about emergency supplies, maybe thinking a little bit more about managing distribution channels, maybe upgrading some of the public water services, kiosks, managing all of those better. It's a huge task. But in the long run, I think the most important lesson here is this is grounds for a totally new economic appraisal of the societal value of piped water supply. Public health engineers have said forever and ever that the benefits of giving people piped water supply at home, although they are huge for the individual, are much bigger for society at large. And if we can't get that message across now, we will have really failed. In terms of sanitation, wastewater management at the moment is probably not the priority issue, although we are going to have to worry in the end about the safety of wastewater workers if they're in places where we think they might be very highly exposed. I think the biggest sanitation thing we have to worry about is that there are lots and lots of people, particularly in urban areas, who go out to defecate. We really need to keep an eye on what's going on in the massive flow of fecal matter that gets out, particularly in urban areas. And the other thing about WASH is that a load of people are still getting sick from a bunch of other water and sanitation related infections, of course. So all of WASH still remains important. We know that COVID disproportionately affects people with underlying health conditions. So we've really got to think about, well, again, going back to Kenya, there's a huge spike in malaria cases. The COVID intervention, essentially what we're looking for is interventions that we know are a good thing anyway and trying to layer them over all of the other things that need to be done. So in summary, I think COVID-19 is a wake-up call. I think it's really important that we make the case, we keep making the case, that we can't tackle this kind of infectious disease if people don't have the means to practice basic hygiene at home. And it tells us, and it should tell policymakers, that WASH is not a charity sector where we just have to help others because it's a good thing to do, even though it is a good thing to do. It's not solely an individual human rights issue, although it is. It is everybody's human right to have decent water supply and sanitation. But neither of those arguments are actually, well, we've never had much luck persuading governments to invest what's needed in improving WASH. I think the point we have to make now is that providing adequate and reliable water supply and soap at home and at school and in health centres and in prisons and markets is actually something we have to do to protect the human rights of the entire population. it's the big stink all over again. The right to protection against a serious existential health threat for everyone is the new justification for WASH interventions, in my opinion.
Thank you, Barbara. That was absolutely fantastic. And we're now open for questions.
I'd be curious to if I may, ask about the financial feasibility of more short-term implementation of WASH as a human right. I volunteered for EWB for a while, and it seemed very difficult to get funding from governments or even charities for very basic projects. And I think if we're going to wait for that sort of timeline that we've traditionally been working with, it's not going to be quite as feasible to keep these sort of pandemics from happening again. And I was wondering, with your background in economics, which I think Tom mentioned, what's your view on that?
Yeah, that's a really, really great question. And I don't have an answer, but a couple of things that I would say. I mean, first of all, yes, a huge amount of money is needed, and that's always the excuse for not doing it. But one thing that's in our favour is I think we can make a fairly convincing case that a lot of the economic hit that the rich old white people are going to experience is going to be a function of us not having provided these basic services. So the cost benefit, if we express it well enough, is going to be significantly higher than we've ever been able to convince anyone it is before. But the other thing that I want to just emphasize is the problem is that water supply and sanitation and hygiene are actually not primarily infrastructure sectors. They are public finance sectors. The really important thing we need is for local governments to be allocating and spending a big chunk of their money on really boring tasks like getting the trash off the streets, desludging the drains, making sure that leaks are patched up in water supplies, making sure that fecal sludge is, appropriately carted to the wastewater treatment plant. And that's the bit that I find really hard to sell. So one of the things I think we need to really do at this moment is make the case for operational public funding for sanitation as a fundamental part of the primary healthcare budget. If you don't run these systems, then your health systems will be overwhelmed when we have the next pandemic. If they're spending X on, cancer treatments every year, then they should probably be spending X multiplied by 100 on operational budgets for water and sanitation, because from a health point of view, they'll get the same bang for their buck. And that's the economic case we've got to make, I think.
Thanks, Barbara. It's quite novel in the UK and in Western countries. We've not had anything like this for a long time, but as you mentioned, other impacts that countries face. I just wondered whether it is enough to push for change or whether it's just same old, same old.
Perhaps a useful fact is that because this is a novel infection and it's highly infectious, disease mortality ratios are quite high. I think what's in our favour is it kills rich people. And that's really crap to say that, but certainly the Indian government have mobilized like I haven't seen them for a very long time. I do get the impression people are taking it quite seriously. I think the big trick for us, again, it sounds awful, but I feel like this is an opportunity we have to seize and keep hold of. And the corollary for me is AIDS. Now, this level of panic that we feel now is not quite what we felt in the 80s about AIDS, but there's something quite similar to it. And the thing is, this is an infection that travels, that moves, that affects everybody. So it's the one moment when I feel like even quite a lot of governments that tend to be a bit paralysed by the ordinary everyday, they can seize that. And I was just talking to a colleague of mine who works in the Ministry of Health in an East African country that should remain nameless. And he was saying, right, this is it. I'm going straight to the top of government and I'm going to tell them that, this is the moment when they have to start funding primary healthcare properly, because if they don't, then their children will die. And so, there is a little bit of a window of opportunity, I think.
Perhaps you'd like to plug your PhD program.
Oh, yes. So if anyone is interested, we have a Centre for Doctoral Training in Water, Sanitation and Health that Leeds, Loughborough and Cranfield. For this year, for this September, we're still recruiting. We've got 3 places at Cranfield and 1 at Loughborough still. We don't have any places at Leeds. But we will be recruiting again next year. It's a 4-year programme, fully funded, working on resilient water and sanitation related infrastructure in the Global South. comes with a package of funding to do your research and 6-month placement in a country of your choice to do useful things.
Barbara is, I think, has lived up to her billing, and I've been generally inspiring. I'd like to thank her.
Thank you for inviting me, and yeah, please be in touch if there's anything I can do as a follow-up.